And folks are morning, everybody. I'm Dave Axelrod, one of the surgeons here at UH. We're going to give everybody a minute or two to join on, and then we'll get started with today's session. We're really excited about it. Terrific. Well, again, welcome to the our Health Services Research webinar for today. We're thrilled to welcome Dr. Jon Fielder to present virtually. He is coming to us from the continent of Africa outside of Nairobi. By way of introduction, Jon is a proud graduate of Williams College in Massachusetts, subsequently graduated with honors from Baylor College of Medicine, went to a mediocre, small, unknown institution in Baltimore, where he was the most Oslerian Hopkins intern. He's had a distinguished career and has worked on the continent, initially in Kajabi Hospital, came back to the States for a few years and has since returned. He leads the African Mission Healthcare as their CEO, and is also a practicing internist. They have awarded over $76 million in grants to 47 partners in 18 countries, and has really been a distinguished member of the international health community. We're thrilled to learn from him and thank him for his time this morning. And Jon, I will turn it over to you.
Well, Dr. Axelrod and everyone, thank you very much for the invitation and the opportunity to share with you. I was requested to share just a little bit about my global health journey. David gave a little bit of background. When I finished my residency, I came to Kenya in 2002. My interest was and clinically still is in HIV and infectious diseases. And so I came to a hospital outside of Nairobi, a teaching and referral hospital called Kijabi Hospital, and took over for an internist who was leaving, who had started some HIV work. This was before the PEPFAR HIV treatment program. And I did that for a couple of years. And then PEPFAR came, and I was part of the scale up of antiretroviral therapy in Kenya. And later had the opportunity to travel around Kenya and help mission hospitals set up their HIV clinics, it was during that time that I came up with the idea for African Mission Healthcare, and that kind of percolated for a few years because I saw the needs of many of these rural hospitals that didn't have the same levels of support that they used to have. Um, as David said, we spent a little bit of time back in the US and then moved to Malawi for 5 years before moving back to Kenya, where we've been since 2014. Um, so today, I our organization does a fair amount of work in various areas, both geographic and clinical across the continent. But instead of just painting with a broad brush, I thought I'd talk about one place in particular as maybe representative of the work we're involved with and the way we see things. Um, and but as a broad overview of African Mission Healthcare, we try to boil it down to what we call the three T's. So we treat patients today, train African healthcare professionals for tomorrow, and transform hospitals for the future. And so under the treating, we do provide direct support for, say, nursing salaries or buying malaria medicines or things like that. We also sponsor a lot of surgeries in various countries and institutions at the individual patient level. Um, our training runs from short courses. We've done a lot of HIV and tuberculosis short course training, all the way up to sponsoring 6 years of pediatric surgery residency and kind of everything in between. And then on the transforming hospitals for the future, that's a lot of infrastructure work around things like oxygen, operating theaters, hospital wards, a lot of housing in rural areas. There's very little housing for faculty, staff, and learners. So that's a very broad overview of the kind of work we do, but we don't we don't do just one thing. We see the institution actually as our client, as an organization, and we are more than a funder in the sense that we have a training team that coordinates a lot of learners. We have an infrastructure team that has engineers and a biomedical technician, and then we have also people who are have a strong background in finance and administration to help hospitals with things like governance and administration. So today I'm going to talk about the Nuba Mountains in Sudan and a hospital there. The politics there can spin your head. I try to simplify it every time, but feel like I go down rabbit holes. But basically, since about the 1950s, when Sudan gained its independence, for most of that period of time, there was a multi-decadal civil war between the North and South inside of Sudan. That culminated in 2011 following a peace agreement with the creation of the country of South Sudan, which is the youngest country in the world. South Sudan has since descended into its own civil war, and the Nuba Mountains was left north of the dividing line, even though it sided with the South during the long civil war with the government of Khartoum in the north. And so they're kind of caught in between and it's almost a stateless area and has been that way for a couple of decades now. It's the population now with the refugees, because now there's a civil war between factions of the government in Khartoum. So with refugees from that war, this area now is home to over 4 million people. Even since I made this slide, there's been a huge influx. And that's a place about the size of Maryland. Very remote. There are no paved roads. There are no utilities, no water, no power. There is Starlink internet in a few places. There's some solar power in a few places, but it's a very isolated region. The Mother of Mercy Hospital was begun by the Catholic Church in 2008. It opened with 3 expatriates and 15 local staff, none of whom were high school graduates. One of those was Dr. Tom Katina, who is still there. War erupted in 2011 at the time of the separation with South Sudan. In 2013, they started a community clinic outreach program, which has since grown to 19 community clinics. There were a few years of a tentative ceasefire, but that has ended now. Almost 3 years ago now, when the war broke out in Khartoum between rival factions of the government, the Nuba kind of sat it out for a while, but now the war has come again. We were part of we for all the way back to around 2012. We were providing some funding, but we really became a lot more involved around 2018. And this hospital was basically operating without a real board and without a real hospital management team. It was basically in a kind of a war footing with a lot of people sort of coming and going, or kind of like almost more like an NGO than a fixed mission hospital. So when we got more involved, we tried to standardize some of that. A health training institute was started in 2022. All the staff who were being sent out for training were going to South Sudan and Uganda and Kenya, and we were doing some of that. But that gets to be expensive, and so a local health training institute was started, starting with clinical officers and midwives, and the first cohort graduated last July and are doing an internship now. I mentioned the war that broke out in Khartoum between two different groups, the army and a paramilitary organization. The population has ballooned over that time. This past year, just within the last 6 months, we started a high dependence unit, which is kind of a step down from an intensive care unit. A lot to take care of post-operative patients, trauma patients, every child who undergoes surgery. They had some bad outcomes, so they now go there. Um, there was a cholera outbreak in 2025 that's mostly controlled now. Um, and I mentioned the internship program. And this coming year, the orthotics and physio department hopefully will be launched, including some outside visiting people to help some of the local trained folks. There's a lot of course, disability. There's a lot of amputations. And then we'll be taking in the first nursing class into the training institute. So here's the geography. Um, Kenya is here, um, and then here is South Sudan. This is Uganda, and then this inset here is Nuba, and Goodell Hospital or Mother of Mercy Hospital is there in Nuba. Nicholas Kristof of the New York Times has done incredible reporting from there, and you can find actually a video that he did on YouTube, or you can, if you have a subscription to the Times, you can read this article called "The Worst Atrocity You've Never Heard of." There's also a movie that you can see on iTunes, done by an American filmmaker called The Heart of Nuba, which gives a very good sense of what things are like there. This is an view shot of the hospital. It's kind of in a square. This is a few years old. There's been some building since this time. Um, there's also an ophthalmology clinic. There's a new pediatric ward, which isn't seen here. The high dependency unit isn't seen here, so there has been some development since this photo was taken. It is the only referral facility in the region. What does that mean? It means that any surgery that there's one other place that can do a C-section. There's a couple of other places gearing up to do a C-section. Again, remember that there are no paved roads. So if a woman goes into labor, she could easily be 4, 6, 8 hours away with, and that would be if there is a vehicle. And a lot of times there is no vehicle. There are very few cars. There are an increasing number of three-wheel vehicles and motorbikes, but not too many cars. They see close to 100,000 outpatients at the main facility a year, over 200,000 patient contacts in the community clinic system, about 9,000 inpatient admissions. The surgeries, it's about 2,800 general surgeries, another 1,000, 1,200 eye procedures. As I mentioned, in 2008, there were no trained NUBA staff, but now there's a total of 305 staff and about 70 are formally trained. So it's really an incredible growth, and it shows what can happen if people are given opportunity and the resources to be trained and to do their jobs. I mentioned Tom Katina. He's been there basically continuously, except for the few times that he comes out. We drag him out. We just dragged him out a few months ago to do some fundraising. That's mostly the only reason he comes out. Um, he's a family doctor who first came to Kenya in the 90s and learned a lot of surgery there, learned from a Kenyan surgeon and some missionary surgeons, and so when he went up as a family doctor, he was kind of a one-man band and could do pretty much everything. Not everything surgically, but he could do surgery, deliver babies, take care of adult and pediatric patients. Um, he is married in the Nuba Mountains. His wife, Nasima, is a nurse who trained in South Sudan, and she's Nuba by background. And they have two children, and they've been there the whole time. So here's Tom operating. I believe this is the old operating theater. And just to sort of give a sense of, of course, it takes a team. It's not just about him. We've trained someone to be a scrub tech in Kenya. I think we've trained at least one, maybe two at Kijabe Hospital in Kenya, and then the anesthetists there have also been trained in Kenya. They're all nurse anesthetists. Um, the top is the high dependency unit. And what we did there is we brought nurses down for a kind of short course in ICU nursing and high dependency unit nursing. And then we've started a few ICUs, so we kind of know what the equipment is, and we shipped it all up there. And there's a an American missionary who does the building there, and he built the unit. Um, Another thing that's happened is that professionals have been displaced from Khartoum. So in the lower right is the dental unit. So the dentist was practicing in Khartoum and fled back to Nuba. I think he's Nuba by background, and so we were able to get a dental chair up there, and so that's a service there now. Um, this is Caesar operating in the eye unit. We sent him to a Kilimanjaro Christian Medical Center to learn how to do eye care. Sam's been, I don't know if you've been to KCMC, Sam, but it's close to where Sam spent time in Arusha, and so they're really one of the best places to send clinical officers. He's not a doctor; he's a physician assistant, and he spent a couple years there learning the basics of eye care. And then there's been teams going out from the US to help mentor him, but then he anchors everything when he's not there and he can do cataracts and everything. So we're sending another one to Tanzania. He might be there now um, because there is a lot of demand for cataract surgery and other eye care. Um, we were just chatting just before everything started with Dr. Axelrod about how an internist got involved with surgical capacity building. This was a paper that we published with a group at Duke. Henry Rice, who's the head of pediatric surgery there, has been out a couple of times to Nuba and took a look at the impact of the surgery in a war zone like that, and found that the return on investment was basically for every dollar you invested in surgery, you got $14 back, which resulted in a year in almost $10 million to the local economy, which is a lot for that region. So it is a cost-effective intervention, even in these very difficult to reach places. And it is very difficult to reach. It's basically a logistical nightmare. We have a team in Nairobi that supports this process with procurement and logistics. We source most things from Kenya. Some things come from Uganda. Some things come from Juba, South Sudan. And then by air or road, and sometimes even by river, things then get sent up. Things go through Juba, South Sudan, then up to a refugee camp in a place called Yida, which is near the border with Sudan, and then they go overland into Nuba. And we try to do one big order a year, but inevitably additional things are needed. Like last year, it was cholera supplies. I mean, of course, they needed more IV fluids and more, gloves and antiseptics and disinfectants. So usually there's a couple of emergency orders throughout the year. Um, it's a very challenging process, and that's why we have a team that's dedicated to it full time. Patient transportation is another huge challenge. You can see the picture on the right here is what you can call the Nuba ambulance. So people carrying a patient to the hospital for who knows how many hours or even days on a local bed because of a lack of vehicles or a lack of money to afford those vehicles. So one of the things that we did with the outreach program is place an ambulance in a central location, kind of a market town where patients can come and then get a ride to the hospital. So it does both routine transfers of patients and then emergency transfers of patients, but a lot more of that is needed, particularly for women's health. Um, One of the things that makes you really optimistic is the students. And I mentioned the training school before. So we started out with a group of 20 clinical officers and 30 midwives. Clinical officer again is like a physician assistant, and ended up graduating 19 clinical officers, and I think we have 28 midwives who will finish this coming June. So that's really exciting. I also mentioned the outreach program, which has 19 clinics and over 200,000 annual patient contacts. There was a measles outbreak a decade ago, and the outreach program was instrumental in putting an end to that, and still does vaccinations today. We're hoping to upgrade 5 of these clinics to basic emergency obstetric and neonatal care centers. We have funding for one of those, and that will be starting in the next few months. I mentioned the ambulances that have been deployed. And then as the graduates come out of the clinical school, the clinical officers, the midwives, and later the nurses, some of them will be absorbed by the hospital. Some of them will be, there are a couple of other groups working in the Nuba Mountains, a couple of NGOs, and some of them will be absorbed by those groups. And then some will be pushed out to the outreach program clinics and help raise the level of care. So just a few lessons when we think about these sort of longer term institutions and institution building. Of course, this is a particularly challenging setting, but a lot of mission hospitals started like this. They may not have been in the middle of a war, but they definitely started in places where there were no paved roads. And there's a famous mission hospital in Kenya called Tenwek, which now has a cardiothoracic surgery center, which we were part of helping to get started. And the reason it's named Tenwek is that it was a 10-week ox cart journey from Mombasa on the coast to this hospital back in the 1930s. So it just really takes decades of vision and mission to see things come to fruition. And often the growth is very organic. We're launching a 5-year plan, uh, which we're going to try to execute against, but no doubt over those 5 years, something else is going to come up that wasn't in the plan, and so um, you have to be flexible. The focus really is on clinical care. I mean, certainly there's a soft boundary between public health and clinical care. I mentioned the outreach program, doing all the immunizations. But the institutions we work with are predominantly focused on, bread and butter medicine. Does someone have access to an appendectomy? Does a kid lose his arm just because he falls out of the tree and breaks his arm? Which I have seen happen, and all my colleagues have seen happen. So kind of bread and butter clinical care. Sustainability, everyone likes to talk about sustainability. The fact is that a place like this is not financially sustainable. And, partners or donors or, you know, uh, anyone looking at this field who thinks that these institutions can be sustainable on their own. I mean, what I usually say to people is American medicine isn't sustainable on its own. It requires government support. It requires philanthropy. And you're dealing with populations that just really can't pay that much out of pocket. Right now, we're still less than 2% of the hospital operating budget is paid for locally. And we have been raising those fees, but we just haven't been able to make much progress. So you have to think about sustainability, certainly in terms of multiple donor funding streams for an institution like this. In other countries, there are sometimes, like in Kenya, National Health Insurance Program, or other types of government support, or patients can pay more, like in Malawi. The combination of what patients can pay and what the government gives in support, and then what external donors give, it's roughly 30 to 40% each, and that gets you close to 100%. So resources definitely still matter. I mean, particularly at this hospital, we're very dependent upon external donors, but systems and institutions also matter. So it's true within African Mission Healthcare that we categorize our accounts by projects and programs, but again, we're really focused on how do we build a system and institutions that will outlive us. So you have to have that long time horizon because development it just takes a lot of time and nothing is easy. And the way I think about it is the American football metaphor of just moving the ball down the field a few yards at a time. That we're not throwing a lot of long passes and Hail Marys. And likewise, nationalization is a process. This is a hospital that's in some ways not been as dependent on outsiders because they've only had one really long-term missionary doctor. There have been a couple of others who've been there for months or even a couple of years at a time. There's another group there now, and they've been there for a few years. Uh, and certainly those outsiders bring a lot. I mean, they bring connections to some resources. They bring, modern medicine. But ultimately the goal is to have it be a totally Sudanese institution, just like it's been with so many of the other mission hospitals that we've been affiliated with. But it takes time. So I think it might be coming. Oh, yes. This is I think one of the AI chatbots gave me this term trilemma, but this idea comes from a colleague of mine who used to be my boss in Malawi and started the clinic where I worked there. And he talks about Perry Jansen. He talks about the the balance of equity, sustainability, and excellence. In that you want to have all of these things. You want everybody to have good access to good care, not any care, but good care. And then you want it to be sustainable without so much outside, help and resources. But once you give up on one of these things, it unbalances everything else. So often what you see is, for example, a sustainable institution, but you don't have clinical excellence. So it's open, but the care is not really great. Everybody's got access to it, but it's not great care. Or you can have a sustainable institution that provides excellent care to paying patients, but then you lose equity. You lose access to care for the poor. So this is just a real challenge at all of our institutions. I think particularly in Nuba, but the problems are not unique to there. So I think that brings my formal presentation to an end, and I hope that leaves some time for questions. Thank you.
So thanks so much, John. That was absolutely an amazing sort of overview and accomplishment and delivering care in an environment that most of us can only dream of dealing with the difficulties. Hopefully people will start to enter some stuff into the Q&A, but maybe I have a couple of questions for you. Um, the first is sort of, you showed the operating room, and we know that, you have to do a lot with a little. There's a really, an amazing paper published in the New England Journal about repairing hernias with sterilized mosquito netting as opposed to the expensive meshes that we all use in the United States and that sort of stuff. Sort of as you sort of think about what, and as technology gets more miniaturized, I think about ultrasounds that go to your phones and that sort of stuff. How do you see some of the technologies that we sort of see in this sort of in these first world environments sort of being able to be translated? What are the greatest needs that you see, moving forward, especially as people think about innovating in this space?
Yeah, thank you for the question. The best example is the one you've given is ultrasound, and I'm pretty sure they have a butterfly IQ at the hospital. Um, and you see those around a lot more now. And when I first came to Kenya, I was the only person in the hospital who could do an echocardiogram. And now many people not only can do them, but they're better than I am. I mean, they're formally trained and I'm not, and they know how to interpret things better than I do. So I do think ultrasound is a great example. Um, unfortunately, so there are some things that have also been great in labs, say things like the malaria rapid determining test kit, so much better than microscopy, and easy and fairly affordable, and can be done very very simply even at the bedside. Then you still have, though, just traditional ways of, say, doing chemistry electrolytes. So you still have to be able to maintain that equipment, source those reagents, and in a lot of those, there's more suppliers. Like, for example, I mean, there's traditionally been some good European companies, and now there's a couple of good Chinese companies. So that's good in the sense that there's more of it, but still maintaining it, transporting it, supplying it is some of the same old problems that have always been there. In surgery, I think like LED lights, LED overhead lights. Those have been great. They have them. It's sort of what the missionary builder there put together. He's kind of the MacGyver of Africa. He can do everything, kind of like a toothpick and chewing gum, and he'll get you something useful. So he put together some LEDs that way, but even the formal ones that we can buy now, like the operating theater lights, they're LEDs, so they're really great lights, and they last longer, and they're more energy efficient. But I don't see them. I don't see them as getting us over the hump of, say, surgical access issues. I see those as so fundamental to as, for example, you have to have the team that I talked about before, but then do you have oxygen? Do you have what kind of power do you have? Who's maintaining the anesthesia machine? How do you keep the supply of the volatile anesthetics there? These are all just sort of bread and butter logistical procurement system issues that are so difficult in so many different places. And yet, if one of those pieces in the chain breaks, then surgery often isn't available.
Yeah, no, I think you're absolutely right. I'm gonna take, there's a question in the box that I'm gonna sort of morph a little bit. Sarah asked about resources and education for folks that want to be volunteers, both sort of short courses and longer courses. So I guess I might ask you kind of as what do you recommend for people who are, physicians, other healthcare providers in the United States that really want to hit the ground running and be most helpful during a period of time, in country? What do we need them to know ahead of time? What are the resources people can avail themselves up to be most helpful to you?
Well, what I usually tell people is if you're going to go to a place, on a short-term trip, try to pick a place and then develop the relationships and make repeated trips. So instead of saying, okay, this year I'm going to Uganda, and next year I'm going to Kenya, and next year I'm going to Tanzania. I think it's so much more helpful to pick a place and really focus on it and really learn, okay, how can I really help here and make a change? I'll give you an example. When I was in Malawi, the clinic there has a long-standing relationship with UCLA, particularly the internal medicine department. And it's been really great because some of the faculty there have been out many times. A couple of the faculty, when they were junior faculty, actually came out for 6 to 9 months. And then others have just every year they're there for 2 weeks. And so when they come, they don't have to say, do we have this medicine or what can we do in Malawi? Uh, or do we resuscitate a patient like this? They know what that is. So I think, that's one part of it. I think another challenge has been for people who come on shorter term trips is that with so much specialization in the U.S., and then you end up, yeah, for 10 years I worked at another mission hospital in Kenya, north of Mount Kenya, and that's in the Kenyan system, it's like a district. It's like a small to medium sized district level hospital. It wasn't a big referral hospital or anything. We had interns, but the cases we saw, I can guarantee you, would require multiple teams of subspecialists at Hawkins to manage. I mean, the cases we would see were just so challenging. And so if people are going to go, they have to be ready for that. Now, if you're a surgeon, you're probably going to be corresponding with the surgeons there beforehand and say, okay, I can do this, or we'll line up some cases for you or whatever. But if you're an internist or a pediatrician or a family doctor, you have to be ready to sort of go back to your residency days. Um, in terms of the practicals, we don't really facilitate a lot of short-term trips ourselves. If people wanted to be involved in NUBA, it's hard to go short term there because it's so hard to get there. So we've it definitely helped people to go for, a month or 2 months at a time. And because we play a different kind of role with that hospital, that's something that we can do. But there are other ways, either a direct relationship. I mean, Sam has the relationship with Steve Swanson in Tanzania, and there are other ways that you can make those direct relationships with hospitals.
Perfect. Sam,
Yep,
I
I
like.
have a few questions. Thanks, John. Um, what do you think are, in your opinion, the three highest impact interventions that really made a difference? Means you highlighted a few like the ambulance, outreach program, but if you have to pick three, what would those top three be?
Mm. Uh, well, I'd probably come back if you ask me again and say another three, but I would say the community outreach program. I mean, just bringing basic care to in a place like that, it's different than say most of the rest of Africa. At least there's usually a village clinic or something where malaria can be treated, right? There wasn't even that in most of Nuba. So getting that community clinic system out, and then trying to raise that level of care, particularly around maternal health and and um, and some basic pediatrics. That's probably number one. Um, and then the training local people. So not being really highly dependent upon outside people. I mean, obviously, I mean what Tom does. There's this other group there. There's a nurse who runs the clinical school, and a family doctor is there, and they've done amazing work. But training local people to fill in, I mean, to be lab techs and in the pharmacy and nurse anesthetists and the nurses and clinical officers and on is definitely the way to go. Um, the third one, might be surgery because it is not available anywhere else. And so go back to that paper that I shared. Um, if Tom were not to be there now, uh, we'd have to try to figure out how we're going to replace, all the surgery that he does. The rest of the hospital could function at some level without him, but right now there's another group, and they had a clinic they have a small hospital that's like 11 hours away, and they had an injury there that I think it may have hit the femoral artery, and their debate was, do we try to send this patient all the way to Goodell, 11 hours away? And they had a medical officer, they a young doctor there, without any residency training. They managed to stop the bleeding and stabilize the patient, but so without surgery, it is 20-30% of preventable death. So if you don't have any surgery at all, you're just going to have so much suffering.
Thanks. I'll just have two follow-up questions. One is, I guess, from your extensive experience in Africa in various resource limited settings, what can we learn from there that could be relevant here? Means we have different kinds of resource limitation in the US, but we do have equity issues. Their rural health has similar problems that some you mentioned. So what can we learn from your experience there that's translatable here? And my another question would be, how is your model different from, let's say, other large scale nonprofits like Partners in Health who works in a similar space? So those two questions. Thank you.
Sure. Thanks. Um, when I my first tour in Kenya, and I mentioned I was involved with the antiretroviral therapy scale up. I did a lot of community HIV work. We had a team, great team, and it was not just sit in a clinic and hope that the patient shows up. Uh, Education, particularly at that time. I mean, now people know much more about HIV and adherence and resistance and all that. But we had to be out in the community. We were in the markets, we were in the churches, we had support groups. At one point, we had 70 support groups. We had transportation mechanisms. We decentralized our care to get it closer to patients. So we did all of that. And then I went back and I worked at the HIV clinic in Dallas. And I was talking to one of the medication adherence counselors, and I said, "Do you guys do home visits?" And she said, "No, the lawyers have said no, we can't do that." And I thought, okay, you have here a marginalized population, and the clinic in Dallas, people with transport challenges, people with all kinds of challenges. Like what do you think? What's happening in between when you see them every month or 3 months or whatever with their care? And it was just a huge, I just felt like this emptiness. How can you provide this care without being out in the community? So, that was one thing. I have very much learned to be an empiricist here. When you practice in Kenya, there is more technology in Kenya. So I was shown an MRI of TB meningitis yesterday. I mean, I was asked what I thought it was, and my thought was that it was TB meningitis. And that's great, but in most of our settings, you can't do those things, and you have to interview the patient, you have to talk to the patient, you have to examine the patient. And I haven't practiced in the US for a long time, but everything that I've heard and people have told me is that, that is not done as much as it used to be. There's a lot of reliance upon tests and technology, and I think something is lost when that happens. So I'm sure many of the sort of Abraham Verghese attitude toward this, and I think I share his philosophy on these things. Um, I think so. Your second question is about the philosophy, how ours is different. I think uh, I, I don't want to say we're certainly not as big, nor do I think, quite frankly, that we're as influential as partners in health. I mean, obviously, Paul Farmer, Jim Kim, and that whole team. I mean, what they've accomplished is remarkable. But actually, I think their philosophy and ours is pretty similar. They're very. I mean, they pick a few institutions and they go in and they work with them. I think the difference is we work mostly with mission. We have work with governments, but mostly with all there's 19 clinics in Nuba are all government clinics. They're not mission clinics. Uh, and they work mostly with government. But I think they're very focused on clinical care, and I think they're very focused on institution capacity building, clinical training. And so the I think the way I turn it around and say, actually, what's difference between our PIH's philosophy and our philosophy, and other groups. And I think a lot of other groups are a lot more focused on public health. So clean water, bed nets, that kind of thing, which is obviously important. But in my opinion, what gets the short end of the stick is clinical care. Because if you look at kind of even definitely after the funding changes with the US government, but even before the funding changes, I mean, what got money? I mean, HIV, malaria, some to tuberculosis, and then vaccinations. After that, it basically falls off a cliff. Like even maternal health care falls off a cliff. And then everything else really, really falls off. And particularly in the context of, okay, how do you make an institution that can do a lot of those things? So I happen to know a particular country, which I won't mention, but when during COVID and a lot of oxygen plants were donated, I know now they've never been used. Why? Because the institutions just didn't work. I mean, there was no power, there's no system, there's no electrical wiring, the transformer, it wasn't there. All the things you need, we put in some oxygen plants. It's very complicated. You need the technicians, you need the training, you need the systems to support all of that. And I think that that's where the international community misses a lot. I think you've got a lot of very big donors who are extraordinarily utilitarian. And if you don't look at institution building, then you can't really look to the crises that are going to come in 5, 10, 20 years.
I know we need to wrap up in the next, minute or two. I guess maybe as a parting comment, you mentioned a little bit of the changes in funding that have happened. So for those of us who want to support the work that you want to do and need to do, what's the what are the advocacy steps? What do we need to do to make sure that, that we continue to engage in this international work, which I think is as crucially important as in for knowledge generation for academic medical centers as anything we do. So what's your charge to the group on this call as we leave today?
Well, let your elected representatives know that you support, global health. Um, that PEPFAR was transformational for Africa. I mean, I was here before and after PEPFAR, and PEPFAR set the continent on not just a different health trajectory, but economic trajectory and I believe political trajectory of stability, at least in those places where PEPFAR has really focused the most resources. So it's good for Africa. It's good for the United States. And it's just the right thing to do. If you're so inclined, on a much smaller level than, the U.S. government, supporting organizations like ours, or Partners in Health, which I think is great, or similar organizations, funds really go a long way here. And we appreciate the support. And then, before the question was if people are going to get involved, using their clinical skills or teaching skills, find that place that's going to be your place that you go to for 10 years or more, and that people know you when you go back, and that you can really, be a part of. And I have seen that with groups that, plucked a mission hospital in Uganda, and that's where I know one place, I'm just thinking of this one group in the United States, and they put in the solar power for it. And that makes just a huge difference to be continuously engaged, on this side.
Thank you, John. Thank you so much. I think we're moving into your other session. I don't, Yi or Abby, if you want to help people do that. Thank you again for John for taking the time, and your work is truly inspirational for all of us. And as Sam said, I think we continue to learn as much from you as you guys do from us. And thank you for doing it. Abby or Yi, if anything else we need to do?
No, that's good. I think